All right, welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database Upgrade Webinar number 2. Today is Wednesday, November the 19th. So welcome everyone and thanks for joining. Really quick agenda, just again, I'm just same as we did last time, just going to cover our timeline for these calls and then we'll hop into our review for today. Today we're going to be covering the diagnosis through esophageal cancer sections. And then as usual, we'll finish up with Q&A. If you do have questions, please feel free to put those into the Q&A. And yeah, put those into the Q&A. I've closed the chat, so it's just easier for me to keep up with, track all the questions via the Q&A. And then also we can download the Q&A so we can help, we'll use those questions to guide us when we're finishing completing the training manual. Excuse me. So our timeline for our GTSD upgrade webinars are last week we covered admission through pre-op evaluation. Today we're going to tackle diagnosis through esophageal cancer, and then December 3rd we will go over thymus resection through discharge, and then December 10th is going to be an open Q&A for the upgrade. So if you have any questions, you've gone through any questions you weren't able to ask during any of the sessions, come back on December the 10th and we'll just have an open Q&A and we'll clarify any questions that we were not able to address during these calls. So we'll follow up with surgeons and come back and clarify outstanding questions that we were not able to address specifically during these webinars. And then, as you all are aware, we go live with this data version on January 1, 2026. So just a reminder that January 1, 2026, for OR dates of January 1, 2026 forward, you should start collecting on this new version 5.26. All right, so let's go ahead and jump into our review for today. If I can get out of this presentation, there we go. All right, we're gonna pick up where we left off last week. So let's start with our primary diagnosis. Variables again, for those of you, if you did not join us last week, on the left, I have a markup version. This is the 526 form. Anything highlighted in blue is new to this version. Anything in yellow crossed out was removed. Over here on the left, again, is the 526 fully marked up version. And then over here on the right is the current data collection form for 526. So I just have the two up for a comparison. So let's go ahead and start diagnosis section. So diagnosis, we did not have a lot of changes. Mainly we clarified a couple of the headings. Mediastinum, we removed the thymoma, thymectomy, the mediastinum gravis, mediastinal mass verbiage, and just renamed it to mediastinum. For our esophageal section, the diaphragmatic hernia and GERD, we added the paraesophageal verbiage to this section. Cardiovascular, no changes. Chest wall, no changes. Diaphragm, esophagus, other, no changes. I'm just going to continue to scroll down. In the pleura section, we did remove one diagnosis. We removed pleural thickening within the pleura section. And then continuing to go down, tracheolarynx, no changes. Trauma, no changes. And then in the miscellaneous, we had a couple of a few changes in the miscellaneous section. You'll see here, excuse me, that we removed abnormal radiologic finding. We removed shortness of breath. And then under other unlisted category of disease, we removed the other primary specify and other primary ICD. Even though we removed these fields, I know some of you still like to have these fields for internal tracking. You do have site-specific fields within the software now. You can work with your vendor to create custom fields for you, but you do have these new fields in your software that you are able to use if you wish to specify the other unlisted category of disease or the ICD. Excuse me, I don't know why my voice is all or froggy, so I apologize. All right, next we're going to move into our operative section. Ruth, feel free to jump in, anytime if you want to add further explanation. So just feel free to chime in anytime.
You're doing great.
All right, our operative section, date of surgery, no change, or entry entry and exit time, no changes with anesthesia start time, end time, procedure start time, end time. Multi-day operation continues. Just select yes or no if the operation continued through midnight. Status of operation, we have our first update here. You can see between the versions, we removed the choice for palliative, and we added choices for palliative elective, palliative urgent, and palliative emergent. So those are the three more descriptive choices for palliative for the status of operation. Assisted by robotic technology, yes or no. Our next change you'll see is under surgical approach conversion and 521. This was unanticipated surgical approach conversion. Now it is referred to as just this surgical approach conversion. I know that unanticipated caused a lot of questions, Ruth, I think in 521, but now it's just surgical approach conversion. Same thing with conversion type. We removed that unanticipated. Now we're just it's just conversion type, whether it is elective or emergent. And then our conversion reason, we just clarified, we added vascular/bleeding. Vascular was there beforehand. We just added the /bleeding to further clarify for the conversion reason. So now we have vascular/bleeding, anatomy, lymph nodes, or other. All right. Okay, I'm sorry, I was just looking at the questions really quick. Let's see. So yes, Carly, before I continue, vendors were given the the specifications, and Paul it just indicated there's 2 vendors in the certification process right now. But yes, vendors were given the specs back in several months ago. All right. After conversion reason, we have a blood transfusion intra-op. No changes there for yes or no. And then our ASA classification. All right. Moving down into our procedures section. Again, not a lot of changes with procedures. You'll notice here under the concomitant procedures, we did add a choice for thoracotomy with mediastinal and regional lymphadenectomy. And of course, that should be listed separately in addition to primary procedure code. So we added that choice for under the concomitant procedures. Esophagus resection, we no changes here. Paraesophageal hernia, GERD procedures, again, no changes. Just the only change, we changed hiatal. We've removed the verbiage hiatal to further clarify, and it's changed that to paraesophageal hernia. Continuing to scroll, no changes to thymus mediastinal mass resection. Next, we have our minor non-analyzed procedures. No changes for tracheobronchial larynx. No changes to bronchoscopy. Pleural space and lung, no changes. Sorry for the scrolling, guys. Look away if it's making you nauseous. Lung other procedures, no changes here. Mediastinum and diaphragm. Esophagoscopy. Is that how you say that, Ruth? Yeah. Esophagus, other procedures, no changes. Chest wall and neck, no changes. Miscellaneous, again, we have a couple of changes here. For the miscellaneous, we removed the choice robotic assisted surgery, capture as an additional code, S2900. And then we added the unlisted procedure nervous system.
That was specifically to capture some blocks that are commonly done in the OR.
All right. Thank you, Ruth. All right. Continuing down in this section for we moved procedure laterality down a little further, so we just relocated it in the 526 form. We did not get rid of it. We simply relocated to another section of the data collection form. For our question resection performed, we added some new verbiage just to make it more clear. We have resection performed for new primary lung cancer. Same thing for esophageal cancer, resection performed for new primary esophageal cancer. So if it's not a new primary or new primary lung or new primary esophageal cancer, you would answer no. If it is yes, if this is a new primary lung or new primary esophageal cancer, you would answer yes, and then you would complete sections F and G accordingly. Thymus resection, yes or no? If yes, then you will complete section H. Tracheal resection, again, yes, no. If yes, complete section I. And then we further clarified, cleaned this up a little bit. It's paraesophageal hernia, yes or no. Remove the reference to hiatal hernia, diaphragmatic hernia, and GERD. So paraesophageal hernia, yes, no. All right. We relocated ECOG and Zubroad score. So we added we made this a parent field to the ECOG Zubroad score itself, which is a risk model variable. So now is ECOG/Zubroad score available? Yes, no, not a cancer patient and not reported, or no, cancer patient and not reported. So if the answer is yes, then you would answer the child field, the ECOG Zubroad score. So I think we've preached enough a lot. ECOG Zubroad score is a risk model variable. So if your surgeons are not documenting ECOG or Zubroad, please work with them to ensure that that is documented so their patients are assigned the appropriate risk during analysis. Before we move on to the lung cancer section, I know there's a couple of questions. Do you know if we'll get a field for trisegmentectomy instead of just having to select segmentectomy as the primary procedure if more than one segment is taken?
As far as I know, there is still not a CPT code for a trisegmentectomy, so it was not added. If that research that I completed is incorrect, and somebody has a code for that, feel free to share it with me. It's going to be too late to add it to this version, but it could be added to a future version.
Yes.
But we generally only add things for which there are actual codes to capture. Everything that I could find said that trisegmentectomy continues to be captured as single segmentectomy. Just in general, outside of this, yes. So
Right.
no change there.
All right. And here's a question. So since S2900 is removed, it will just no longer be captured.
I think approach is captured somewhere else, which is why we removed it here because it was redundant. So yes, it will not be captured as a procedure, but your approach will be captured elsewhere.
Let's see. We'll get to that one in just a second. Let's see. Will you also be accepting the Karnofsky score? Some of our medical oncologists use Karnofsky instead.
Yep, that's fine. You can continue to crosswalk those. It'll be in the training manual.
Okay. Perfect. And are we still capturing hiatal hernias? We'll get to that. I don't know if you want to address that, Ruth, but we'll get there when we get down to that section.
Yeah, we're capturing paraesophageal hernias. So not like congenital hiatal hernia, but yeah, paraesophageal hernia you'll still capture as an optional module. There's no changes to what we're capturing from a hernia perspective. I think that the previous header was just misleading about what we were supposed to be capturing previously. So hopefully that's more clear. It's not a change, it's just a clarification.
Allison, I saw you have your hand up. Did you have a question? You can unmute if you had a question. I'm not sure. Okay, get your hand down. All right. Okie dokie. Let's move on to our lung cancer section. So If you were to answer yes to new primary lung cancer resection performed for new primary lung cancer, then you would complete section G, lung cancer. Procedure laterality, we removed the not applicable choice and we just added the words lung. So we have right lung, left lung, bilateral for those choices. And then I saw questions, why did we remove not applicable? What do we code for sternotomy? Sternotomy, I can't say it. Sternotomy and laterality.
Um, I think it was removed because you're either resecting right lung, left lung, or both lungs, which would be bilateral.
Mhm.
So if you do a sternotomy and you remove right lung, you'd pick right.
Right. All right. Okay, doke. So next for diagnosis, clinical staging done, yes, no. We had some changes here to the clinical staging methods. So if clinical staging done is yes, no. If yes, you would complete the clinical staging methods. We have PET CT, brain CT, brain MRI, invasive mediastinal staging performed, and then we added, if PET CT, what was the SUV max of the primary lesion? Um, we removed the variable who performed the biopsy, and then we also removed the method of mediastinal lymph node sampling. Ruth, did you want to give any thoughts behind of why we removed these two? I know we haven't done anything with this information, specifically the who performed the biopsy, that the surgeons felt like it was just we weren't doing anything with it. It was an easy
Yeah, I think they
um
feel like this question has essentially been answered.
yeah.
And from um, invasive mediastinal staging performed the method, the overwhelming majority of invasive mediastinal staging is EBUS at this point. And so they felt like, again, there's really not a question there that we're looking to answer anymore. I do think too that the IR needle biopsy option was being selected in error very, very
Mhm.
often. And so it was just a messy sequence with no value add. And so we got rid of it.
All right, moving on. Our lung cancer tumor size in centimeters, no change here. Lung cancer T stage, no changes here. And then our lung cancer nodes is a risk model variable. No changes here. We just removed the verbiage. Like all of this is included, I think, in the training manual. But it just took up a lot of form. So we're just trying to tighten up the data collection form. So we just removed all of this verbiage. If into for lung cancer nodes, we added into classification. So if you answer N2, then you would complete the N2 classification into A, into B, or unknown. Lung cancer metastasis, no change here, M0, M1. Of course, this is also a risk model variable. Moving on to our pathologic staging. For lung cancer, we have lung cancer tumor present, yes, no. If yes, then you'll complete the following variables. We had a lot of data managers, a lot of requests for a way to collect synchronous primaries. So we did add the variable synchronous primaries resected within the same encounter, yes or no. I don't know, Ruth, if you had any other clarifications or any other details on synchronous primaries.
Yeah, I think in general, the data managers were hopeful that there would be a way to capture the pathology for synchronous primaries separately. So, like, there would be a synchronous primaries, yes, and then there would be an opportunity for you to enter the TNM staging for each tumor that was resected. Ultimately, the task force did not feel like that would be valuable data to collect. And so they wanted to just capture whether synchronous primaries were present. And then we'll continue along with the same methodology that we have in the past, where you're going to enter the pathological TNM staging for the lesion most likely to impact the patient's long-term survival. So sort of a middle ground.
Yeah. And then also, if we were to collect TNM for it, it would just add that much more, data burden collection. If you wish to collect that data on your end, you're, obviously more than happy to collect it on your end. You can work with your vendor again to create, site specific fields or ways to capture it internally. For the final pathological tumor staging, we added T2. I don't know how that got left off in the past, but T2 was added back to the lung cancer tumor. I'm sorry, added back to the final pathological T stage. We added lung cancer tumor size. We were not originally collecting lung cancer tumor size in the pathological staging. We have added that as a variable. Also, another new variable is molecular testing performed. Yes, no, or unknown. For those of you that collected data in the REDCap form, you will notice that this was brought over from, from the REDCap, from the neoadjuvant. So, molecular testing performed, yes, no, unknown. If yes, the molecular testing performed on biopsy or surgical specimen. Was it the preoperative biopsy, surgical specimen, both, or unknown? And then mutation identified. So which specific mutation was identified from that testing? We have the EGFR exon 19 deletion, exon 21. I'm not going to go through all of these, but again, you can see all of the mutations that were identified. If you were not on the previous call, just really quickly, these do not use intended for future use fields. These are included in case there are other mutations that are identified that the workforce may decide that they want to start capturing. If this is the case, we would activate one of these do not use fields. You will not see these in your vendor software unless STS explicitly instructs your vendors to activate one of these fields. But instead of waiting for another upgrade in order to add a new field or a new choice, we have added these do not use these intended for future use specific fields. All right, after the mutation identified, we are capturing PDL 1% tested, yes or no. If yes, we want the PDL 1%, less than 1%, 1 to 50%, or greater than 50. If you answer 1 to 50%, we are asking you to provide the PDL 1% value. Visceral pleural invasion, this was moved, it's not even, it was just moved down to this this form, this space, visceral pleural invasion, yes, no, unknown. We're also now collecting lymphovascular invasion. Choices for yes, no, unknown. STS present, yes, no, or unknown. And then our next variable is invasion of adjacent structures. We added mediastinum from the previous version, so I think that was a choice that a lot of data managers have requested be added back to invasion of adjacent structures. I think it was in a previous version. Ruth, correct me if I'm wrong, but it was removed, but we've added it back. And then we move down to our lung cancer, it was previously referred to as lung cancer nodes assessed. We just clarified it to where actually nodal stations assessed instead of just simple lung cancer nodes assessed. There were no changes to the stations. Again, we just made a clarification to the previous variable as lung cancer nodes. We just renamed it to pathologic end stage to what it should be. Pathologic end stage, again, you'll see we added into classification, into A and into B and unknown. So if you answer into, then you will be required to answer into into classification. Next, we have pathologic M stage, previously referred to as lung cancer metastasis. So, and we added MX and M1. So we no longer, we have MX, M0, and M1. All right. Moving on to lung cancer histology. Previously, we collected for histology in the previous version, it was just adenocarcinoma. We have now broken that out to adenocarcinoma mucinous and adenocarcinoma non-mucinous. If adenocarcinoma non-mucinous is selected, then we are now collecting the primary histological pattern present. So if adenocarcinoma non-mucinous, you would select if it was acinar, lipidic, solid, papillary, or micropapillary. No change in grade and how we are collecting the grade. Lung cancer resection margins positive. We just updated the verbiage. Lung cancer resection margins positive for invasive carcinoma. Yes, no. There's no change made to lung cancer resection margins positive pathology. We've added a new variable, distance from the invasive carcinoma to the closest margin in centimeters. And we added adjuvant therapy. We're asking if chemotherapy, immunotherapy, radiation, targeted therapy, none or unknown. If chemotherapy or immunotherapy or targeted therapy are answered, then you would select the specific chemotherapy or immunotherapy, the specific therapy that was used. I can't pronounce these words. I'm not going to try it. But again, you'll see we added choices. We added these 3 choices. I'm not going to try and pronounce them. It's just not, it's not fun. If you select other, we're just asking again that you please specify the other chemotherapy or immunotherapy or targeted therapy that was used. And finally, our last question that was added to the lung cancer section, we are now asking if this case was discussed at a multidisciplinary meeting, tumor board, lung nodule conference, or equivalent. We have choices for yes, no, or unknown. That is our review of the lung cancer section. I see we have some questions. So Ruth, let's tackle a few of these before we move on to our last section, the esophageal cancer. All right, Lynn, sequence 1800. I was wondering if they're going to add a specific time frame for lung cancer tumor size. As you know, they have the use CT if less than 3 months. If not, use the PET. If both are over 3 months old, use the CT, but they don't have a time frame. So if a CT is 9 months old, for example, can we use it for sizing? Can't use it for staging, so wanted to see if they're going to make the sizing and staging the same time frame for this version. It's a great question.
It is a great question. We're actively working with Dr. Vallada on sorting through this question right now, along with an adjacent question. So I don't know the answer to that just yet, Lynn, but the task force just discussed this in the context of a much broader request that was brought through, and it will certainly be included in the training manual. Sorry for not having more on that one just yet.
Yeah. We'll have more on that hopefully by our end webinar, our Q&A webinar. I think that's on the 10th, I think.
Yes,
so
certainly we'll have it by the 10th.
Yes. So yes, thank you for the questions. So will pathological staging of synchronous primary be the highest T&M staging? Ruth just is something like the highest probability of impacting long-term survival.
So it's not necessarily based only on TNM staging. So if you had a small, like a lower T stage, but with a much more aggressive pathology, you would capture the more aggressive pathologies. So think about like, and it's unusual, right? But like if you had an unusual instance where you had like a smaller, I don't know, small cell cancer or whatever that was resected, you would capture that versus capturing like an adenocarcinoma or whatever. But you have to consider like all of the different pieces of the of the pathological report in order to determine which one to code. I would say that if you're not sure, that you can connect with your surgeons and they can give you some guidance. If the pathology is exactly the same for both tumors, then it's a straightforward, just pick the larger or
Okay.
more, yeah, just pick the larger.
Okay. Oh, I lost my mouse. Hold on. I'm sorry, guys. I have three screens and my mouse just disappeared on me. Okay, great question. All right. So not about version upgrade. Melissa, if you want to send me that question, that's fine. If I get a chance to, I'll come back to it in the end if we have extra time. So, Mindy, is this the final version, no longer a draft? So, I have not posted the final version yet. I do not anticipate any changes to this form. We do have vendors going through certifications, but I do not intend any further changes to this form. Final versions will be posted on the website. I'm planning to have them posted by mid-December. Um, maybe before then. I need to talk to Carol, but and to Paul as he's currently doing vendor certifications. But the final versions will be posted on the SES website. Hopefully, we'll continue to give you updates throughout these upgrade webinars as to when I anticipate to have them posted. But I do not foresee any changes being made to this form. Paul's saying, Paul's probably shaking his head. Yes, there will be no more changes. Mary, please.
Yes.
Yeah, I think I'll cry too.
Yes.
Um, Mary, please remind me what MX is. I think that was under histology. Oh, pathologic M stage.
Yes,
MX.
X means that metastatic disease was not evaluated. Similar to if you had NX, it would mean that no lymph nodes were resected for evaluation.
All right. Let's see here. Discuss at tumor board. I assume that's after surgery, and then someone said we have a lot of tumor board prior to surgery.
Yeah, so we've talked about this one, and the training manual isn't final yet, but the current thought coming out of the task force is that they would like to capture both lung nodule conferences or whatever you call that at your particular institution, which occurs before surgery, and or conversations that occur post-operatively at like a oncology tumor board setting. And so it was hard to figure out where to put this sequence exactly on the form. So we ended up dropping it into this lung cancer section because you should be all the way through your pathology at this point, and it made a little bit more sense sequentially, but it is intended to capture both post-op tumor boards and pre-op lung nodule conferences or equivalents.
All right. Is it neoadjuvant or adjuvant therapy on the path report? What did I say?
Sorry, what was the question?
She
Oh,
just said, is it neoadjuvant or adjuvant therapy on path report? Dora, can you clarify?
um,
Let's see. There's a question. Let's see. In the current version, invasion of adjacent structures was added in 5.26, but for the current version, do they capture it anywhere for now? In 5.21, is there a way for them to capture invasion of adjacent structures?
can you scroll to that sequence? Sorry,
Oh yeah.
should be
Invasion.
up.
Yep. Invasion of adjacent structures. It's a new, we added it.
We only added mediastinum. Oh, you passed it.
Oh, sorry. Oh, there.
We only added mediastinum.
Yeah.
If there's invasion of the mediastinum in the current version, it was intentionally not there in the current version and isn't captured anywhere.
Yeah. Yeah, so sequence 1875 in the current version. We added mediastinum, yeah. Um, let's see here. Will the tumor board question be only in regards to primary lung cancer resection? Oh, hold tight, Mary. There's another question for esophageal. So there's a separate question in the esophageal cancer. Okay. Oh, it read adjuvant. Yes. So adjuvant. Sorry, Doreen. That was probably just I misspoke. Um, we typically do not start adjuvant therapy right after surgery. It is collected within 30. Is this collected within 30 days?
It is collected within 30 days. The surgeons are aware that that is the case for many.
Mm-hmm.
And just do the best with what you have in 30 days.
Yep. Let's see. Would you select mediastinum invaded with positive nodes?
That's a great question, Brian. I need to flesh out the official definition of mediastinum. It's an IASLC, I think, definition. So I'll add that to the training manual. I don't recall it off the top of my head, but
Yeah.
I can probably grab it real quick off the IASLC website.
Yeah. Thank you, Brian. Let's see. Thank you, Doreen. Okay, I'll come back to other questions when we get there. Hold on. Let's see here. All right, so we've got about 20 minutes left. Let's hop over into our esophageal cancer section. All righty. Oh, sorry. Sorry for my scrolling, guys. Okay, esophageal cancer. Um, So if resection for new primary esophageal cancer is answered yes, then you'll complete section H for esophageal cancer. Our very first change under the pre-op evaluation, we did remove the variable has the patient lost 10% of body weight in the last 3 months. So we are no longer collecting that variable. Staging procedures for clinical staging done, we added EGD as a choice and we removed the choice for other. So again, just added EGD and removed other. Esophageal, if clinical staging is not none, so if clinical staging is one of those choices, then you would answer our next set of variables. So esophageal tumor, we added choices for T4A and T4B. Otherwise, no other changes to esophageal tumor. Clinical diagnosis of nodal involvement, no changes here. We have yes or no. Esophageal cancer metastasis, we have choices of M0, M1, no changes under esophageal cancer metastasis. We added esophageal cancer histologic grade as we were not collecting this in version 5.2.1. So now we are now collecting histologic grade GX, G1, G2, and G3. So this is a new variable that we will be collecting. Tumor location, just a minor change here for lower thoracic. We just clarified. In the past, it was 30 to 42 centimeters. So now we just made that 30 plus centimeters. I think there was I don't know, there was some that were above 42 centimeters. So we just clarified that to 30 plus centimeters. Neck approach. Oh, I'm sorry. Before we get to neck approach, we did remove the variable planned staged procedure, yes or no. So we are no longer capturing if this is a planned staged procedure. For neck approach, we removed the choice for robotic. So we have none, open, and cervicoscopic. If neck approach is not none, was lymphadenectomy performed? Yes or no? We removed yes with dissection and yes without neck dissection. We're simply just asking if neck lymphadenectomy was performed, simply yes or no. Thorax approach, no changes there. Abdomen approach, we removed the choice none. And then we have choices for laparotomy, laparoscopic, robotic, and thoraco-abdominal. That's the new choice, thoraco-abdominal. If laparoscopic or robotic, we're continuing to answer hand assist, yes or no. Anastomotic method, we added the choice for cervical esophagostomy. Esophageal conduit, no changes. Pylorus management, there were no changes for pylorus management nor J-tube placement. Esophagus pathological staging. So if esophageal cancer present is yes, then you would answer esophageal tumor, no changes. No esophageal cancer nodes, no changes. Metastasis, no changes. Histopathologic type, no changes. Histologic grade, there were no changes here. Total number of lymph nodes sampled, harvested. If the number of nodes sampled, harvested is greater than 0, then we are now collecting the total number of malignant nodes. We're also now collecting MSI, microsatellite instability. So your choices are high, intermediate, low, unknown, not reported. We're now collecting the HER2 new status, positive, negative, unknown, not reported. Resection margins positive, yes, no, no changes here. And then if yes, select all that apply, you have proximal, distal, and radial. Adjuvant therapy, select all that apply. So your choices are non-chemotherapy, immunotherapy, radiation, targeted therapy, or unknown. And then same as we had for lung cancer, the last question for our esophageal cancer section is discussed at multidisciplinary meeting, tumor board, GI conference, or equivalent. And of course, the choices are yes, no, or unknown. All right. So that completes the review for the diagnosis through the esophageal cancer section. I do know, see, we have some questions. So again, please feel free to put your questions into the Q&A or you can raise your hand. So let's go ahead and tackle our next set of questions. Let's see here. When will the new training manual be out? Ruth and I are working on it. Plan to have it out in December, hopefully the beginning of December. Is that correct, Ruth?
Yes, sorry. I was looking at the training manual to answer a different question.
Oh, no, no, you're
Over to
fine.
unmute.
No, you're good. You're good. But yeah, it's a work in progress. And like I said, we're still working to get questions from our surgeon leaders. So we are working as quickly and as best as we can to get that out to you all as soon as possible. Let's see here. All right. So for esophagectomies with mediastinal lymph node dissection, how do I capture the lymph nodes? I don't see anything in the list other than under lung cancer concomitant procedures.
Sorry, I was looking at a different
No, you're
question.
fine.
Where were you at? Sorry.
No, you're sorry. For esophagectomies with mediastinal lymph node dissection, how do I
Oh,
capture the lymph nodes?
that's what I was actually looking at to see what the guidance was there. Sorry.
No, you're good.
Can you go to the next question and we'll come back to that one?
Yep. Okay, so in the lung cancer section, the adjuvant therapy is for therapies after the resection.
I think on that one there's confusion. If you want to go back up to like the
Yep.
section,
Oh,
neoadjuvant
sorry.
section.
That's adjuvant, the neoadjuvant section.
Yeah, like scroll to the top of I think you passed it.
Oh, yeah. Sorry, guys, for the anger scrolling. Long.
We're gonna keep going down a little.
Where am I?
Did I not? Right here.
Yeah.
So these questions right here are about adjuvant therapy,
Mhm.
not neoadjuvant therapy.
Right.
There's
Does
also
that,
a section for neoadjuvant therapy, but it's not this section.
right.
So we're
Does that,
collecting both.
right.
Maybe that helps. They're both are in here.
Yeah. So yeah, this for in the lung cancer in this section, it's adjuvant. Up in the previous up above, I don't want to angry scroll, but I'm going to, so look away if it bothers you. Um, Up here, the neoadjuvant therapy data collection section. So if the patient received neoadjuvant therapy for primary lung or esophageal cancer is yes, and that is up above. That question is up above. I don't want to, if so, for neoadjuvant, that is collected here for lung and esophageal. And then in each specific section down below in the lung cancer section, we ask adjuvant therapy. And then also in the esophageal cancer section, we ask adjuvant therapy. But the neoadjuvant is up in this in that section up above. Let's say section D, I think. Um, all right. Will there be further information in the new training manual regarding how multifocal tumors are to be captured in regard to the new synchronous primary field?
Yep, we'll include that, Winnie.
Yep, great question. Thanks, Whitney. And why did we remove robotic and neck dissection? What if robotic is used for this approach?
The surgeons felt like that was a
Yeah.
never occurrence. It's a very like the neck incisions are shallow incisions and not performed with robots.
Yeah, I think Dr. Cedar said he hadn't like he could not even think of.
Like they couldn't conceptualize a way that would even ever happen.
Yeah.
You would have, so if you have a robotic esophagectomy, um, the neck incision currently probably is being done without the robot and you're capturing it as a robotic esophagectomy because there's just not a way to do that piece of the surgery robotic. So it's considered minimally invasive and all of those things already.
Mhm.
It just hopefully eliminates confusion about how that portion of the surgery is occurring.
They have a prospective study going on using robots on neck dissection.
Well, we'll let Dr. Cedar know.
Yeah. How will we differentiate between know and unknown for discussed at multidisciplinary meeting?
Um, I,
No.
oh,
Yeah. Oh no, go ahead.
I mean, I guess what I would say is if you're reviewing your tumor board cases and your patient was not discussed, you would answer no.
Right.
If you don't have access to who was discussed at your tumor board and lung nodule conferences, then you would say unknown.
Right.
Or if you would like get the patient referred from an outside institution and you have no idea whether the outside institution discussed them at a lung nodule conference, but you know that they weren't discussed at your oncology conference, like you could say also again unknown in that instance.
Yeah. All right. Deanne said that she normally finds her tumor board multidisciplinary meeting information under the media tab in Epic if you're using Epic there. Ah, thank you, Deanne. Did you want to get back to the
Oh,
question?
sorry, I got distracted. Do you want to answer Melissa's question?
Let's see here. Not about version upgrade. Is there any way to identify the individual case's risk of mortality and or morbidity? We can use our vendor software to know the risk for ACSD, but I'm not sure about GTSD. I don't see it in IQVIA after upload. Are you referring to like the ACSD risk calculator, I assume, Melissa, or the risk score? We don't have that for GTSD like we do for ACSD. There is a GTSD calculator out there, but we don't have anything in, like we don't calculate risk scores in GTSD the same way that we do for ACSD. Hopefully that answers your question. Um, all right. And then back to Anne's question. for
I think we're gonna
esophageal.
have to clarify that further. I'm looking in the training manual right now, and it specifically talks about regional lymph nodes for esophageal cancer. Um, so we'll get that added in.
Okay.
Thanks for the great question, Ann.
Yeah. Great question. Yep. All right. While I'm waiting to see if there are any other questions, um, just a reminder really quickly. Oopsie. Sorry about that, guys. Doo-doo. Our next webinar is going to be on the 3rd of December, and we'll tackle our thymus resection through discharge. And then again on December the 10th, we'll have our open Q&A. Like we said, we'll come back and answer any questions that we were not able to address today, or any questions that you have that came up after the webinars. Let's see. I may have missed it under the lung cancer for lymph nodes. Is it still 1 to 10, even if more lymph nodes have been sampled? We increased that number of nodes sampled. I think you would get a warning, I think, in IQVIA if the total number of nodes assessed sampled was greater than 10. We increased that for this version, Mary, so you won't get that. I'm sorry, I just assumed your name was Mary. We just assume increase that normal range. So you should not get that warning in IQVIA if you enter greater than 10. All right. Any other questions? Got about 5 minutes. All right. Okay, so since we don't have any other questions, we'll circle back with our next session, and we'll tackle that thymus resection through discharge on December the 3rd at 12 o'clock Central Time, 1 o'clock Eastern. Thanks everybody for joining today. Hopefully it was helpful. And we'll look forward to seeing you guys on the 3rd, and we'll review thymus resection through discharge. Thanks everybody. Thanks Ruth. Hope you guys all have a great day.
Thanks, Leigh Ann.
Thanks. Bye-bye.